everybody, and thank you for the opportunity to speak with you today about our lessons we've learned after 82 cases of magnetic control growing road. We're speaking about early onset scoliosis, a spine deformity that appears before the age of 8. This is of the consensus statement of the SRS. We know that the lungs and the chest cage develops at the first years of life. We know that the spine length is growth, especially the early years and the beginning of the second decades. And we see that the number of 18 centimeters of D1, T12 is here, and we'll go back to that later. It is well established that there is a difference between adolescent idiopathic scoliosis and infantile scoliosis, that infantile scoliosis has more morbidity and more mortality compared to the general population. Our goal of treatment is to control the deformity while allowing spinal growth, and by that also lung development and chest cage development, and also giving the patient and his family normal life. We can translate these goals into numbers also. We want the lengths between T1 to T12 to be at least 18 centimeters. This correlates with good lung functions. Our options is to exhaust the conservative treatment. We can always observe and see if there is a progression. We use the brace and casting. Fusion in this early age is not a good option, correlates with morbidity and mortality. So the growth-friendly systems are classified by SCAG to destruction-based, compression-based, and guided growth-based. And if we'll go to the destruction-based, they requires a surgery every about 6 months. So it was also established that the more surgery you do, the more high risk for complication. So we needed a device that will lower the need for repeated surgery. We were introduced with the MAGIC technology. This is a magnetic control growing roads. There is the actuator, the engine in the middle of the road. It being controlled by a remote control. This maneuver is doing at the clinic. It's painless, it is short, and creates a distraction on every visit. So if we'll take an example, this is a paraplegic patient after a resection of neuroblastoma at the age of 8. Has a significant deformity. We implanted growing roads, and after 4.5 years, 22 distractions in the clinic, elongation rate of 7 millimeters a year, we completed the definitive posterior spine fusion, and this is his last follow-up visit. So if we go by these principles, so all the satisfying cases are alike, but each unsatisfying case is different in its own way. So I want to take this few minutes to discuss with you the cases that didn't succeed, the cases that made us change our way of treatment. So in the last 7 years, we completed 82 cases. We have 24 cases with at least 5 years of follow-up, and 53 cases of at least 2 years follow-up. You can see the diagnosis differential. So about complication, we had 6 proximal anchor pull-out. We had 3 infection, 1 MMC, and 2 after Vepter implantation, 3 rods breakage. We completed definitive spinal fusion in 8 patients. During this procedure, about 3 of them, 1 had loss of signals, which fully recovered. 1 had anaphylactic reaction to blood products, so we staged the procedure, and 1 had proximal junctional kyphosis. So I'll go through these cases, examples and lessons we've learned, categorizing them by the diagnosis. So in the idiopathic group, this is a case of a 7-year-old with a JIS. She's skeletally immature, was implanted. This is her first standing X-ray. 2 years post the surgery, after 10 distraction, you can see at the proximal anchoring, you can see the pull-out of the screw. Requires an unplanned surgery to do a revision. we realized that a screw or only screw doesn't have a way to control the deformity in the sagittal plane, and we changed our our technique, applying a hook, understanding that the power on the sagittal plane doesn't hold with the screw. We left the lower screw in order to have forces on the destruction plane. So we had 37 cases since then doing a combination of hooks and screw. We also apply a protective brace for about 4 to 6 months, and since then we had only one pull-out. So the conclusion in the idiopathic group, proximal anchoring is an issue. We do a combination. We apply a brace. We do the destruction at the clinic every 2 months, 2 to 3 millimeter each time. And when we have a revision to do, we change the diameter of the rods from 4.5 to 5.5. In the syndromic group, this is a case of undiagnosed syndrome. You can see the kyphosis, and it's meaningful here. We implanted the magic control. After 1 year, we can see the proximal junctional kyphosis. We applied 4 weeks of hollow gravity traction, and then we revised her to definitive spinal fusion. In her last follow-up, 1 year post the surgery, you can see again that she did a proximal junctional kyphosis, but it is stable, so we didn't revise it yet, let's say. In another case, again a syndromatic case, myasthenia-like syndrome. This is a kyphoscoliosis. The challenge here is the proximal anchoring naturally. So again, we did 4 weeks of hollow gravity traction, getting some correction, and then we anchored to the ribs, like in a vector construct, and continue to do the destruction to the ribs, trying to control this deformity and gain time of lung development. So in a syndromic patient, they are very kyphotic most of the time. This challenged the proximal anchoring, also challenged the actuator. The actuator is bulk and unamendable. So in the 4.5 millimeter rods, we have shorter actuator. It's also shorter destruction, but it gives you more way to control the sagittal plane. And brace is not always an option in this kyphotic patient. In the neuromuscular group, this is an example of CP GMFCS4. With this deformity, we applied magnetic control growing rods. After 4.5 years, what we can see here is especially the pelvic tilt. Okay, after 16 destruction, it completed the spinal fusion when we went down to the pelvis with a construct. And again, this is an SMA type 2 patient. We implanted magnetic control growing rods, again, going down to L4 and not to the pelvis. And we saw again that he's developing a pelvic tilt. So when we revised him, we had to revise to change the rods. We went down to the pelvis. So in this case, in a central cord disease, again, a patient that have a deformity without yet a pelvic tilt. We went all directly down to the pelvis, and this is him standing, and he even do some steps currently. So conclusion, in neuromuscular area implantation is an issue. The levels, we usually go on the upper instrumentation to T2, and in the lower instrumentation, we are liberal with going to the pelvic fixation. Also here using the screw and hook combination. In congenital cases, this is a hemivertebral congenital case. First was treated by a Vepter, then we exchanged the rods to magnetic control growing rods, and then also when we did the exchange to the rods, we did a hemivertebral resection. This is the point in this case, that you can do a hemivertebral resection and hold it with the magnetic control growing rod, and this is his definitive fusion. In this case of a spondylocostal dysostosis, we first was treated by a Vepter when she was 2 years old. She completed 9 destruction, and you can see the lower rates of the destruction. The deformity and the congenital deformity is very rigid and make it hard on the magnetic control growing rod to do a destruction. We can see the rod breakage and the revision, still doing very small steps. And another case of spondylocostal dysostosis, again, treated with Vepter, almost no elongation. We did hold the deformity, needed progress, but we didn't do any destruction. So in this group of congenital scoliosis, we think that maybe there's not enough power to the engine of the rods to create a destruction, especially in unsegmented bar, but we do control the deformity. My colleague David Lebel presented this, some of these results in the SRS meeting in 2016. We then summed up 33 patients. We did see that most of the correction we get at the first procedure, and we get some length, and we can control the deformity and the length of the spine. In the future, we'll have more and more data about these implants. We can see that, since the FDA approval, we have more and more publication during the years. We have some concerns, short concerns, that we don't have a strict guideline or very good guidelines about the upper and lower instrumented vertebra. We do have unplanned surgery due to rod breakage, pull-outs, and we need to finalize our technique in order to avoid this unplanned surgery. Long-term concerns is the metallosis that we can see in some of the cases. This is a picture of a revision of a MAGIC. As you can see, the metallosis around, we don't know the effect of this metallosis on the patient. We need to have some guidelines about when to do the final fusion. It's a high-risk procedure, have more complication in relative to other spine procedures, and naturally the cost of these implants. So if I'll summarize it up, a magnetic control growing rod shouldn't be the automatic response to early onset scoliosis. First, we need to exhaust the conservative treatment. We need to challenge our indication in cases of kyphoscoliosis and cases of unsegmented bar. The anchoring technique is crucial, and try to avoid unplanned surgery. And we need to learn how to share the knowledge better. We need to remember that we are lucky to treat kids that can turn every challenge into a smile. And this is our morning round, and it's very nice. And we don't work alone. We work in a very high-skilled and professional teams that helps us complete these treatments. Thank you.